About heart rate with our last video, we're going to talk about stroke volume with this video. Okay, so we've got three different outcomes for this one. So what's end diastolic and systolic volume, which we've already talked about, how to calculate stroke volume. Okay, and we're going to talk about something called the Frank-Starling Law, and then we're going to talk about inotropic agents. Last time we talked about chronotropic, this time we're going to talk about inotropic. So just a quick refresher, end diastolic volume is what's in the heart, the amount of blood that's in the heart, specifically the left ventricle at the end of the filling or relaxation phase, or at the end of diastole. And systolic volume would be the amount of blood in the ventricle at the end of emptying or contraction. And stroke volume is just the difference between the two, or in other words, it's how much blood is leaving the left ventricle with every contraction. Generally speaking, we express this in milliliters of blood. Okay, so maybe a typical value might be about 100 milliliters of blood. One other definition that we need to know is something called venous return. And so venous return is just how much blood's returning back to the heart. Do we have high venous return? Do we have low venous return? Okay, but we need blood to get back to the heart so we can oxygenate it and get it out to the rest of the body. Now, if you remember from the Wiggers PowerPoints or the Wiggers lectures, we've got end diastolic volume here, and end diastolic volume will always be greater than end systolic volume. You're going to have more blood in your heart, in your ventricle at the end of filling than you will at the end of contraction. Okay, and so this difference here, sorry, my line's not running, this distance right here, this would be stroke volume. Okay. So this leads to something called preload. So what is preload? Well, preload is the pressure or the stretch or the force that's being exerted upon the ventricle prior to contraction. It's proportional to end diastolic volume. Okay, think about a water balloon. Going back to my water balloon analogy, how can I increase pressure in my water balloon? There's two ways. One, I can put more water in it, or two, I can actually squeeze it. Well, during diastole, the heart's not being squeezed, and so it's got to be the amount of blood that's back into it. So as I increase end diastolic volume, I'm going to increase preload. So how does this change the relationship between the length of a muscle and the tension in a muscle cell? Now, as we talked about with a skeletal muscle, as if we lengthen out a skeletal muscle too much, we don't have very many cross bridges, so we don't produce as much force. However, it's a little bit different in a cardiac muscle cell. The more stretched out they are, the greater the number of cross bridges. The greater number of cross bridges, the more force. And so we call this relationship between the length of a cardiac muscle and the force it can produce the Frank-Starling principle, or the Frank-Starling law. And so here is what we can see from this. Okay, so end diastolic volume is on our x-axis, stroke volume is on our y-axis. And so as you can see, as we increase end diastolic volume, for the most part, we increase stroke volume. Now there gets to be this point here where we kind of plateau and maybe even drop a little bit, but this is a massive amount of blood. Okay, 300 milliliters of blood, that's almost, that's like almost 3/5. Okay, it's about 60% of like your normal 16-ounce water bottle that you pick up at the store. Okay. That is really, really high. Normally, we're right around here. Okay, but as we increase a little bit, our stroke volume goes up. Now, we can change this relationship with inotropic agents. Okay, remember, chronotropic talks about heart rate or time, how often the heart contracts. Well, inotropic have to do with contraction. So if we have an inotropic agent, that's something that's going to change the force of contraction. So if we have positive inotropic, we're going to increase contractility, which will increase stroke volume. Negative inotropic will be the opposite. Okay, and so some examples of things that will cause that will be the sympathetic nervous system. Okay, norepinephrine, we release norepinephrine. That's going to increase the strength of contraction, and we'll talk later about how that happens. Okay, depending on specific ions, that can affect it. That can be both positive and negative. Or certain types of drugs. We can give someone what's called a beta blocker, and that will prevent the heart from contracting as hard. So how does this work? How does the sympathetic nervous system and norepinephrine specifically, how does that change the force of contractility? Well, if you remember, norepinephrine is released from postganglionic sympathetic neurons. This will bind to beta adrenergic receptors, and we really focused on the adrenergic Okay, beta receptors are on the heart. We'll talk later about alpha receptors, which are actually on arterioles. But these beta adrenergic receptors are on the muscle cells of the heart. And what this does is this activates a G protein coupled pathway. Okay, and this will ultimately activate a protein called phospholamban. Okay, if you remember from our muscular unit, there is a pump on the sarcoplasmic reticulum called the calcium ATPase pump. Now there is a lot going on in this figure, and I want you just to focus on this part right here. That's that calcium ATPase pump. Phospholamban, which should be shifted a little bit, basically makes that pump work more, okay, or increases the activity. And as a result, what happens is we increase the amount of calcium that goes back into the sarcoplasmic reticulum. And so by having more calcium stored in the sarcoplasmic reticulum, that's going to increase the gradient that exists when we have a subsequent action potential and we open up the ryanodine receptor. Bigger gradient means a greater release of calcium. More calcium means more cross bridges can be formed because calcium will bind to troponin, which moves tropomyosin out of the way, which allows actin and myosin to get together. Okay, so how does phospholamban affect cardiac contractions? It makes them stronger. By putting more calcium in here, so we're just going to say we have lots of calcium, when that door opens, it's going to rush everywhere. And there's going to be a lot that leaves. I don't know where the door is here. Okay, but we're going to allow for more cross bridges. So what's this going to do to the action potential? It's actually going to change it. Okay, so norepinephrine, not only does it increase the activity of that pump, but it also increases calcium permeability during the plateau phase. So how's that going to change this action potential? Okay. And what's going to happen is we kind of get this second little hump here. So this is due to increased calcium. Remember, initially we have enough calcium going in that's counteracting the potassium going out. That's supposed to say calcium. It doesn't look like it. Okay? But if we increase the amount of calcium that's going into the cell, we're going to depolarize the cell more. However, we're also, remember, we increase the activity of that pump, so we're actually getting rid of calcium at a higher rate, and so the action potential duration actually decreases. Okay? Instead of going this long, whatever it is, we cut it to this much. And that's important. Okay? So we have a reduced muscle cell, cardiac muscle cell action potential, which means we have a lower absolute refractory time. This is good because this means we can have more frequent contractions. Okay, so to kind of put this all together, if I increase calcium permeability in the T-tubules, more calcium will go into the cell. This, along with the fact that I've increased that calcium ATPase pump on the sarcoplasmic reticulum, means I'm going to have stronger contractions in the future, and I'm going to reduce the absolute refractory period so we can have increased action potential, increased cardiac muscle contraction. This makes sense. This is a good thing because if my SA node's firing at a higher rate, well, I need my muscle cells to be in a position where they can contract more often. However, the parasympathetic side doesn't do anything. We don't really have parasympathetic, we don't have acetylcholine receptors on the ventricle. So even when we increase the parasympathetic side of things, that doesn't really change the force of contraction. What will change the force of contraction is if I increase or decrease the amount of norepinephrine that's available.